Great. Okay. Welcome, everyone. This is Giovanna Giuliani from the California Healthcare Foundation. Thanks for joining today's webinar. This is our monthly CIN webinar, and today's topic is on the expanding role of medical assistants in provider organizations. And we have three great presenters that I'll introduce you to in just a moment. Before we get there, just a few housekeeping items, things that often come up. This session will be recorded, and we will post both the slides and a link to the recording on our CHCF website that you see the link for there within a week. We will also push out this information, both the presentation and the recording, to all the registrants via the email you provided when you registered for this webinar, so you don't have to go looking for it in a week. And you can also then forward that email to colleagues within your organizations or outside that might be interested in this and couldn't make it. To ask a question, and we really encourage questions, it's great when we have so much sort of interaction and feedback throughout the course of the webinar. So please feel free to chat questions at any time. Someone just asked for me to speak a little bit louder. I increased the volume on my phone, so hopefully that sounds better. So again, feel free to chat questions at any time during the presentation. I'll be moderating the chat function for the presenters, and we'll queue them up if possible throughout the presentation, but we'll also have time at the end dedicated for Q&A. Because we have such a great audience on the line, I didn't want to lose this opportunity to tell you about the CHCF Healthcare Leadership Program. It's a part-time leadership program for clinically trained individuals and emerging leaders. And our next cohort is being recruited for now. We have had 13 cohorts to date. And the next cohort, which is cohort 14, applications are due May 15th. I included a link there, which I'm not sure that you can actually click on, but what I will do is cut and paste that link into the chat function as well, and you should be able to access it there. So I did want to direct you to that website if you are interested in learning more about the leadership program. So as I mentioned, we have three great presenters today. Really wanted to thank them for joining us. And I'll just give you a brief introduction of the backgrounds of these three individuals, and then we'll turn it over to hear from Catherine Dower first. So Catherine is the Health Policy and Law Director at the UCSF Center for Health Professions. At the center, she directs the National Innovative Workforce Models and Healthcare Project and co-directs the Health Workforce Tracking Collaborative, which assesses healthcare workforce challenges, including supply and scope of practice. She is engaged in several efforts at the state and national levels to better understand and reform health professions regulation and legal scopes of practice, including having served on the committee of the Robert Wood Johnson Foundation Initiative on the Future of Nursing at the Institute of Medicine. Then we have presentations from West County Health Centers. We have two great individuals from that organization. Dana Valley. Dana has been employed at West County Health Center since 2003, and she has worked as a medical assistant and lead medical assistant. In 2007, as the health center transitioned to PCMH using the care team model, her responsibility was to develop the new and expanded role of the care team medical assistant. She's currently the Associate Director of Quality Management for West County, where she is involved in several exciting QI projects. Sheena Toledo has been employed at West County since 2008, and she's worked with the agency medical director to pilot the first care team within the agency. She's been instrumental in the expansion of the Sebastopol Community Health Center, and she's helped create a cohesive and high-functioning medical assisting team at that site. She has worked as a care team medical assistant, lead medical assistant, and medical assistant coordinator. In 2013, she became the MA supervisor for the agency. Her role is to empower and coach West County's MAs to be able to work at the top of their scope of practice and act as the leader of the care team. So with that, I'm going to turn it over to Catherine. One of the reasons I just wanted to give some framing for today's call, this is obviously, I think having individuals working at the top of their scope of practice and thinking more innovatively about roles on care teams and how to best develop care team cohesion and think about roles and tasks and responsibilities of each of those care team members is obviously a very hot topic. And to just provide a little bit of framing, Catherine's going to share some research today on innovative care team models, and we wanted to provide on-the-ground information from Dana and Sheena as well about how they're doing it at a particular clinic. So that's the frame for today, and with that, I will turn it over to Catherine, and I'll advance your slides for you, Catherine.
Great. Thanks, Giovanna. And hello, everybody out there in webinar land. It's always funny to do these webinars when I can't see everybody in person, but I trust that you're all out there and listening attentively, because this is actually one of the most interesting and most promising projects that I've worked on in a long time. So I'm actually delighted that the webinar is happening, and I'm very happy to be talking about this project. Our project is called Innovative Workforce Models in Healthcare, and the subtitle is Utilizing Medical Assistants in Expanded Roles, mostly in primary care, sometimes in some specialty care practices as well. On the next slide, I mention our mission because for those of you who don't know, the Center for the Health Professions at UCSF, we are about transforming healthcare through workforce research and leadership development. The program that Giovanna just mentioned, the CHCF Leadership Program, is actually administered at the center, and we run several other leadership programs. But I work on the research and policy side, so I do that workforce research bit, that half of the house. And so we've been around for about 22 years now, I think, looking at workforce research, health professions, policy issues around the country. We're located in California, but we're actually national in scope in our research and our policy work. We were approached several years ago now, about 5 years ago, by the Hitachi Foundation. So the next slide outlines their Pioneer Employers Initiative, and this was a new foundation for us to work with. They were looking at companies across America that provide career advancement for frontline workers. They were actually looking at various sectors, not just healthcare by any means, looking at manufacturing and other sectors, but they were looking for factors that make companies successful while empowering those frontline workers, then disseminating promising practices and trying to replicate successful models. And they approached us to come up with we negotiated with them and designed a project that would look at medical assistants, because we thought that medical assistants really fit that category in America in terms of a growing profession that was being used and really supported and developed quite a bit in healthcare, in better care teams and new models, new practice models. So the next slide talks about the 3 criteria that we used for sites that would be included in our study. We were looking for sites that were using medical assistants in expanded roles where they had outcomes in 3 areas. One, of course, we were looking for improved patient outcomes. That's always critical to the work that we do, so there could be no compromise in safety or quality. We also were looking for organizations that had improved organizational efficiency or sustainable financing. So we weren't looking for just one-off grant-funded projects, which may or may not be good, and we know there are lots of those out there, but we were looking for ones that were sustainable on a financial basis in a relatively permanent fashion. So that was another criteria. And then finally, and importantly to the Hitachi Foundation, was that the sites had to have career advancement for the medical assistants. So they wanted to ensure that there was no exploitation of frontline workers. We weren't looking for sites that were just using and exploiting the lower level workers to do more and not rewarding them in some way. So that career enhancement included not only salaries and benefits, but also educational advancement and career advancement, so promotional opportunities for the medical assistants. The next slide, on slide 8, is a map of the 14 sites that we ended up doing in-depth case studies. We actually looked at hundreds of possible sites around the country that were using medical assistants in innovative ways, and many of them appear to be terrific models, and we don't mean to be too exclusive, but not all of them met those 3 buckets of study inclusion criteria. So in many cases, the medical assistants were doing interesting things, and they were getting good patient outcomes, but we weren't seeing career enhancement or advancement for the medical assistants themselves. So out of the hundreds of possibilities, we narrowed it down to 14 sites across the country, and we went and visited those sites after doing preliminary phone interviews, and we spent a lot of time at the sites touring and interviewing the entire staff as best we could, so clinicians, the frontline workers, the medical assistants, the nurses, and also administration. So we talked with executive directors and CEOs and CFOs, et cetera, to find out how they made these models work. We went coast to coast. We did red states and blue states. We looked at urban areas and rural areas. So there was no exclusion in that sense. The next slide, on slide 9, I've got a list of the 14 site visits. We published a case study on each of these, and they're available on our website. I just realized that our website's not until the last slide, but it is futurehelp, all one word, .ucsf.edu. And again, you'll see the slide at the end, and we can make these slides available to anyone who's interested. So there are in-depth case studies on each of these sites that we visited. The drivers for change at these sites did vary quite a bit, and I want to mention that, although I'm not going to go in-depth in the examples now, but it's important to understand that the drivers did vary. So in some cases, they were trying to meet increased demand or productivity challenges. In some cases, there were safety or quality concerns, and so they were redesigning their model to address those. You know, in some cases, they had one of those dreaded sentinel events, which is a euphemism for a really bad outcome, and they needed to address some problems in their practice models. In some cases, they were addressing costs. So sometimes they just could not meet their demand given the current financial model, so they had to trim costs. And in some cases, they had some real challenges recruiting and retaining personnel at all levels, from the provider clinicians all the way through nursing staff and frontline unlicensed staff. So lots of different drivers for change. And I mentioned that you can see the details in the different case studies, but I mentioned that before we get into some of the things we're going to be talking about this afternoon. On slide 10, I wanted to note that we did look at different types of sites. So a lot of folks assume that everyone we looked at was a traditional FQHCs. We did look at 4 FQHCs, but we also looked at 3 academic health systems. So they're not immune or unable to integrate these new practice models. We looked at 5 integrated health systems that were not academic. We also looked at a standalone multi-specialty care clinic and 1 multi-specialty medical group. So we had lots of different types of sites in our pool of study participants. On the next slide, just to give you a little bit about what we're doing, we have been doing presentations around the country. We've been doing a number of webinars. We've been doing workshops here in California and in other states. And then we're working with the Hitachi Foundation to develop some short videos as well. So we're doing a lot of dissemination in addition to the publications that I mentioned, case studies that are published on our website. Lots of different approaches to getting the word out and sharing this information, and we continue to learn as we go forward. Slide 12 has just a map of the workshops that we've been doing. We've actually done quite a few in California over the past couple of months, and some of you might have attended some of them. Slide 13 is the map of the tours that we were able to do. This is another mechanism that Hitachi funded us to help disseminate information. And this was really an interesting way to share. Again, we're used to the academic setting where we publish things and try to get into peer-reviewed journals, and we try to get the word out that way through very nicely crafted documents, written documents. But one of the ways that we shared this information was to bring people who were working in various practice settings, usually in primary care settings, and at different levels. It might be the executive director, it might be the medical director, it might be some nursing or medical assisting staff. And we would bring those people to these high-performing sites. They were able to look at the site in action and see how it actually played out. So we took people up to South-Central Foundation in Alaska. We took people to Utah. We took people to the sites in New Jersey and also in New York City. And so those photos, I share those because it's only when you get there that you can really see how the call center, for example, on the bottom left, that photo of the call center at the University of Utah, how that looks, because they've got a whole floor dedicated to taking calls. And I mean, this is a large system, so they have the volume to justify that. But it's really interesting to see it in action. We have an entire floor dedicated to taking and triaging the calls. And that photo in the top left is of one of the floors at the South-Central Foundation site in Anchorage, Alaska. And so you can actually see in person that the team, the primary care team, all shares the same desk. They share the same space. So you can write about that and people can talk about it till we are blue in the face, but until you go up there and you see the doctor and the medical assistant and the nurse and the behavioral health specialist sitting together and talking about the cases together all day long, until you see that in action, sometimes it's not as clear. And then in the upper right, I've got a photo of one of the huddles at the special care clinic in Atlantic City. And this huddle was, they're a great model. They do a full staff huddle every morning as clinic starts. And I emphasize this one because it's, again, you can read about it in the literature, but when I was there, I had the great opportunity to hear as they were talking about the patients who are coming in for the day. One of the medical assistants said, okay, we're going to be seeing, you know, Mrs. Smith today, and the doctor said, oh, well, so we saw her a couple weeks ago, and we ordered that test, and so now we're going to have to order test B. And the medical assistant said, no, actually, you talked about ordering test A, but you never actually ordered it. And without missing a beat, the doctor said, oh, thanks so much, you're absolutely right, let's order test A. It was an exchange that doesn't happen in all practices because there was no hesitation. They were really working as a team. Those two people were talking directly with each other and with full respect for the information they had to share with each other. So again, until you can see those things in action, face-to-face, in person, they don't sometimes sink in. On slide 14, I've got a quick summary of the 3 different models. We tried to organize the various sites that we saw into 3 different models, one being the ambulatory intensive caring unit that has been developed and spread by a number of people, including Arnold Milstein. So a number of you might be familiar with that, the AICU model. We also saw some cross-trained MA team model practices. Some examples here include the High Plains Community Clinic in Lamar, Colorado, University of Utah, University of California at Davis has a cross-trained medical assistant team model. And then we also saw the integrated multidisciplinary care team model at a few sites, including the South Central Foundation site up in Anchorage. I'm going through this quickly. We don't have time to go into them in detail. They are in the case studies that we have, and we talk about more about these how we categorize them and how we set up a typology. I just briefly mentioned the different models there. What I want to talk about today in the next few minutes is, starting on slide 15, are the steps, almost regardless of the model that is chosen and regardless of the site. These are some of the themes that we saw. These are the 4 steps that the sites needed to go through to really integrate and the medical assistants into the primary care team. So the first step is the medical assistant has to deal with the medical assistant training itself, developing the curriculum and clarifying the roles that they will be playing. Second step is dealing with the reimbursement and making the business case because it has to be financially sustainable. The third step is dealing with provider and staff engagement in these new practice models. And fourth, and importantly, especially for this particular project, but I'm finding it to be important for all the practice models, is that you need to have career advancement opportunities for everybody on staff. I think that makes a big difference in whether you're going to be successful or not. Slide 16 is about the medical, so this is going to the step 1, medical assistant training curriculum and roles. Some of the roles that the medical assistants were playing, they did vary from site to site, as might be expected, but generally they were there to support the provider visits and the exams. But in many cases they were meeting with patients individually. Sometimes they were handling their own panels of 80 or more patients. They often were helping with individualized patient care plans. They often were doing the follow-up by phone or email or even texting now with the patients. Some of them were conducting health education classes. In a lot of places we had this, we saw this, excuse me, this effort to embrace the don't move the patient, move the care mentality. So they were bringing as much care as possible into the exam room, even bringing in, taking the co-pays in the exam room. Sometimes the medical assistants were serving as scribes. In not all cases was that the situation, but in some cases they were. And then, of course, the medical assistants could call for lab results. They could schedule follow-up visits. They could do some readings on glucometers, helping with referrals, making sure that the patients got the referral appointments. A lot of times they were doing patient history. So they were actually documenting the patient history and and working with the electronic health record to take down that history so that the clinician could come in and see the background had already been done. And they were also doing follow-up on medication adherence. So this is just briefly an overview of some of the things that medical assistants were doing above and beyond the traditional room the patient and take the blood pressure. Slide 17 is a couple more things about that we saw that are relevant and really important for medical assistant roles. A number of places said that they were hiring for attitude and training for skill, so that they really were looking for people who had good interpersonal skills, who were bright, who were interested in learning, interested in working on a team, which doesn't come naturally to everybody. And the sites found that they could train for skills. They could train for medical assistant skills. Some cases they were hiring out of medical assistant programs, whether community college or private programs, but they often had to augment that. And sometimes they were hiring straight out of high school or another field altogether, people who had not had medical assistant training, but they were able to train them into those positions as long as they had the right attitude. Relational skills were ultimate importance. People needed to be able to understand and work with the patients and also be able to work as a team member. Again, that was critically important. They do need to have basic medical assistant skills. If they didn't get it prior to hiring, they had to learn it on the job, and that sometimes is a major time commitment, but some of the sites were doing that. I do want to mention that in California, it is important to clarify scope of practice rules and regulations. So in California, and this does vary across the country, there are some slight variances in what medical assistants can do. But in California, they may not provide any, they may not conduct any invasive tasks. They may not assess. They can't treat or diagnose. Those are the four big things that are forbidden. But they can do a lot of technical support services. The regulations actually spell out a couple other things that they may not do, and I'm going to just quickly look at my notes here. They may not administer any medication through the IV line. They may not independently perform triage. They can't administer chemotherapy, and they may not administer any anesthetic agents, including lidocaine, so the whole range of anesthetic agents. But those things aside, there's also a very long list of what they can do, and then there's also this broad and rather vague concept that they can perform technical support services as long as certain criteria are met. And so we do have, I have prepared a summary of the scope of practice rules and regulations for medical assistants in California that's available on our website. Again, it's futurehealth.ucsf.edu. And as long as you go through I use the STAR analysis, and that is that you have to be sure that the medical assistants are supervised, they have to be trained, they have to have been authorized to perform that particular task or service, and records have to be kept. Those are all really important and must be adhered to, the STAR analysis. But with those in place, medical assistants can administer medications. They can do shots, including flu shots. They can perform skin tests. They can provide patient information and instructions. There's a long list of things in a broad, again, a broad area that hasn't been detailed that they may perform. So there's a lot that medical assistants can do in California. On slide 18, we move on to the second.
Catherine, can I interrupt? Sure. Catherine, can you hear me? Sorry, I just want to interrupt for a second. A couple questions before we move on about MA scope of practice. We knew that there would be lots of questions about that. And then from Morgan about the website that has the summary of scope of practice. I will try and find it while we're on the phone and put it in the chat box. But if I can't do that, I will send it out when we send out the presentation and the recording of the slides. A couple questions, Catherine. Invasive excludes venipuncture in California. Is that correct?
No, it does not.
You know? Okay.
It does not exclude venipuncture. They may perform venipuncture or skin puncture for the purposes of withdrawing blood. That's specifically in the rules that they can do that if they are trained and supervised to do so.
Okay. One question from Joseph Fernandez. Can they give medications that are co-signed by a licensed nurse, such as ceftriaxone? This is usually reconstituted in lidocaine. That might be too specific.
I can't answer that because I'm not a clinician, so I don't know what that means. They may not administer any anesthetic agents. So if there's an anesthetic in that, I would think that that would be no. But they should check with the medical board as the ultimate authority on this.
Okay. Great. And again, I will search for that link and also at the very least share it in the email when we send out. So we're on slide 18, Catherine, now if you want to continue.
Great. Okay, good. So dealing with the reimbursement and business case, this is important as well. One of the big challenges that we had when we were doing the study is to realize that sites don't keep the same type of financial records from site to site. Nobody has. So we had a really hard time doing compare contrast, and many of you know that. But and there's also different incentives. So in some places, people are trying to increase revenues, and other places are trying to decrease costs. And sometimes those are short-term costs, and other times when they're in more of a system, they're trying to decrease long-term or downstream costs. So the drivers, the incentives, and even the way people keep their books vary considerably. But a number of sites were maintaining very good and meaningful records about the impact that the change in their care team had on their finances. They also had good information on organizational efficiencies. In a number of places, they were able to reduce wait times. They were able to increase provider productivity, which often translates into increased revenues. It does depend on sometimes whether you're a fee-for-service versus capitation can make a big difference in how you can organize your care team. We saw that quite a bit. The capitated models, or even as we're moving towards bundled payments, had a little bit easier time being able to integrate medical assistants and other providers or other staff onto the team that could not bill independently that would be otherwise would have to bill independently under a fee-for-service model. So sometimes the capitated arrangements were easier. We did have some good examples of improved returns on investment, though. At the Special Care Center in Atlantic City, they're dealing with union patients, so it's a specific arrangement with the union that's unionized. The casino workers are unionized, and so they're dealing with those patients. And their patients cost over 12% less per patient per month than similar union patients seen in other clinics. We also had a good example from High Plains Community Clinic in Colorado, which is demonstrated on the next slide, on slide 19. They did a cost savings estimate, and they were able to improve productivity, so they were seeing more patients per hour per provider under the new care model. So they were able to increase their revenue per hour, basically, per visit, and that translated into added net revenue. If you cost the whole thing out, it won't go down line by line, but added net revenue per team per year of over $72,000. And so they were doing a cost analysis to see if they could afford to bring in one new medical assistant, and they could, because their medical assistant salary was $28,000, $29,000. So they were still seeing a savings of over $40,000 per team per year, and that translated to a significant across 7 teams at this clinic. So they had the most intensive ratio of medical assistants to providers that we saw anywhere. They were using 3 medical assistants to each provider and seeing really good outcomes. So a really interesting model. I just used that example because it's one of the few that was easy to put on a slide. But different sites are using different ways to analyze their finances. The next slide is about step number 3, and that's getting provider and staff engagement in these new care models. It's not easy in many places to change the care model, the practice care model. And so some of the ways that people went about doing that are outlined in our case studies and kind of summarized here. One big issue, of course, for everyone working at these sites is to make sure that the patients are getting good care. So if you could improve patient outcomes, that got better provider and staff engagement. It made sense. It made it more meaningful. So at virtually all these sites, as I said, that was one of the study criteria, the sites were seeing good patient outcomes. They saw improved chronic disease outcomes. We have some stats here for High Plains patients having better A1C and blood pressure and cholesterol controls. South Central had good controls as well. They had better screening for their patients. We saw better wellness in terms of smoking rates, child immunization rates. South Central Special Care Clinic in Atlantic City, because they were part of a larger system, they were able to look at the downstream costs as well, so they were able to reduce unnecessary hospitalization. It was down over 40%. So these were all really good patient outcomes that were resulting from the new care team models. The next slide is a little bit more about getting the provider and staff engagement. So slide 21, it does take team training. Again, you could have really good medical assistants in some places, but if the entire place wasn't interested and committed to working as a team, you weren't going to get anywhere. So almost everybody needed to go through some sort of team training, had to clarify roles and responsibilities and scopes of practice for everybody on the team. It made a difference if the providers, the clinicians, were able to work on developing the training modules for the medical assistants. So they were actually part of, in California, that's actually part of the regs, is that they should be involved in developing the curriculum for training and then signing off on competencies. Making sure that the providers are participating in the huddles made a big difference. Everybody participating in the huddles makes a big difference. Sometimes the providers were precepting the medical assistants on a regular basis throughout the day, and that was a really interesting training model that we saw, where the medical assistants would check in with the providers regularly with questions that they had about specific patients or about specific conditions, and the provider was precepting them all day long. And then at a number of places we saw a certain, a specific team would pilot it, would pilot the new model, and that all the other teams would see that that team was doing well, that they were getting good patient outcomes, and that the team was going home at 5 or 6 in the evening and weren't staying late. The provider wasn't staying late, in particular doing charting until 8 or 9 or 10 o'clock at night. So when other teams could see that the pilot team was effective and the quality of life for everybody on that team was better, there was a lot of incentive for the others to buy into it. And then finally, the step 4 is about developing career advancement opportunities for those frontline workers. So this slide talks about the fact that a number of sites really did have to grow their own and were interested and committed to training medical assistants into other positions, including things like limited license rad techs or farm techs, or into health coaches or community health workers. And I comment on that briefly because I've done a lot of work with community health workers as well, and it's interesting how in a number of places those terms, community health workers and medical assistants, are sometimes used interchangeably. Sometimes there's confusion about their roles. And in some places, community health workers are seen as lower on the career ladder compared to medical assistants. And then some places it's the flip. So we saw in some sites the there was a career ladder for entry-level medical assistants to move up to a community health worker role, and with that to see a bump in their salary and in their also an expanded authority and increased or expanded role. So interesting how the different sites are using different ways to develop a career ladder for frontline workers. And then, of course, many sites have now instituted supervisor roles so that medical assistants can progress through a number of career opportunities up to supervisory positions. Some sites are offering on-site or online training or offering certification for the medical assistants, getting authority from the certifying bodies to offer that certification. And then we also saw, of course, some paid bumps for promotions or for specific outcomes with individual patients or panels of patients. Slide 23, I put this slide in because it was important to show South-Central up in Alaska. They're very concerned with their with their staff retention. They had a real hard time with keeping the staff on board, and so they had these turnover rates when they started tracking in 2008 of over 20%. They had total turnover. These lines are the total turnover rates, and then the Alaska Native turnover rates. The Alaska Native employee turnover rates were over 37% when they started tracking, and that was a shame. They were really horrified that those numbers were so high. So they made a committed effort to make sure that the staff were taken care of, that they had career opportunities, that they were all given professional development plans upon hiring, and so they were able to reduce their turnover rates to 15 and 17%, 15% overall, and 17% for the Alaska Native population. So these sorts of practice models really have an impact on retention as well. On slide 24, I just go back to my 3 criteria for the study. This improved patient outcomes, improved organizational efficiency, and career enhancement for medical assistants. that, in my mind, has also turned out to be three main components for primary care redesigned and improved in this country. So it has been a really interesting project, and I think that these three components they do need to work together, and attention needs to be placed on all three of them. Slide 25, I do make a quick mention of a couple of things that I think are kind of the oil to help those gears move. You have to address physical space, everything from shared space or common space for the care team so they can work together to good working environment. Everyone we saw was using electronic health records and using them well. That's really important, and you have to have committed leadership from your executive director, CEO level to make sure that these practice redesigns take hold and are able to be sustained. The last couple of slides are quotes from some of the folks that we interviewed. The first one is a quote from some medical assistants. One of them said, "At first, with this practice redesign, it was panic city around here. I was not happy with this because they felt overwhelmed, like they had to do even more. But then after the design was really implemented, she said, now I feel more a part of the team. I feel like I give 110%. I feel much more important." So that giving 110% was a good thing. Slide 27 is a quote from a nurse from before the redesign was really in place. She said, "Nurses do not like people taking roles they would traditionally have." And then afterward said, "We cannot afford to hire 40 RNs to do vital signs. RNs have enough experience and judgment to really do the higher level stuff." So that was coming from a nurse who saw the value of the redesign. And then slide 28 is from a provider, and this we heard over and over again. First saying, "I felt like I was on a treadmill going as fast as I could without producing many results." And then afterwards saying, "One of the biggest barriers is giving up work to the team. You feel you need to be responsible for everything, but you need to realize that other people are capable of handling some of this work." I'll stop there. The last slide does have our contact information, and I know there's probably questions, but I'll need to stop. I want to hear the other presenters. So thank you so much.
Great. One question for you, Catherine, before we turn it over to West County. Do you have any examples in your research of MA activities directed at community conditions or total population health, such as advocacy for places to walk or to get nutritious food? Did you see any of that in your?
Only in the places where the medical assistants were actually moving into community health worker roles, I would say. So not so much if they were playing a fairly constrained role in the primary care center itself. But if they moved up to a community health worker role, then definitely. And some individuals definitely brought up these issues as they would bring them up with their provider team. But the whole medical assistants in the clinical team weren't doing that much advocacy work.
Great, thank you. So Sheena and Dana, you should have control of the presentation now.
And I think we do. So we're really excited to get to share our model of delivering care to our patients. And it's really neat to be able to see medical assistants front and center in the discussion. We're now more than just medical assistants, which is very empowering. A little bit about our organization. So we're an FQHC in West Sonoma County. We have 3 primary care sites in 3 very different locations with their own unique patient populations. We have a dental clinic in its own location, a teen clinic in its own location. We do outreach at a day labor center, and our newest venture is a wellness center in its own location, which is really exciting to be able to offer alternative and integrative health services to our patient demographic. We're really spread out, as you can see, and so it poses its own unique challenges. We take care of about 14,000 patients. 86 are under 200% of poverty level. When I first started working at West County, we had about 65 employees, and on any given day, we're about 150, 155 employees. So we've grown an enormous amount, especially in the last few years. We have about 22 medical providers, 2 dentists, about 12 mental health counselors. I think we added a few more, and a 0.7 FTE psychiatrist. I'm actually going to turn the presentation over to Sheena, who's our agency medical assistant supervisor, and she is going to show off a little bit about our medical assistants' responsibilities and roles.
Hello. So before I switch slides, I wanted to talk a little bit about what was the catalyst for our change in the agency. We decided that we wanted to improve our quality of care to our patients. We wanted to provide high-quality, comprehensive care without provider burnout. We knew that we had to make changes. So the
Sorry, Sheena, this is Giovanna. Can you hear me?
Yes.
Yeah, I'm having a really hard time hearing you. I wonder if you could put it off of speaker and see if that helps. Can you pick up a handset?
Okay, just a moment. Okay. Is this a little bit better at all?
No, it's not better, but it could be just me. If folks could chat in, it's just sort of garbly, your voice. I don't think there's anything we can do, but I guess I would, if you're picking up the handset, that's the best we can do. So I would just go ahead and continue.
Okay. I'm going to try to be a little bit louder here. So I was mentioning the catalyst behind the change in our agency and how we did know that we needed to make a change to be able to provide the kind of care we wanted to give to our patients. We knew we needed to make a change, and the first change that we made was having a ratio of providers that's 1 to 1.5 MA. It was, people are probably thinking, how did we make this change and how did we afford this change? And so the first thing is we had to have leadership and our board really all on the same page and all with the same vision and all moving towards the same goal. We had to make some sacrifices in the areas of we have a smaller admin, we only have one HR for our entire agency, so we really were all committed and on the same page, and that was the catalyst for the change. So this is our care team model for West County Health Centers. As you can see, our patients are in the center. The smaller circle represents our core care team, which includes the medical provider, the care team representative, which is also the front office, the care team medical assistant, and the RN case manager. In the past few years, we have also increased our front office ratio from 1 provider to 1.5 front office. We've also made a huge leap and changed our RN ratio to 1-to-1 nursing. So we have made a lot of changes, and it hasn't been easy. The outer circle represents our extended members of our care team, patient navigator health coach, health educator. Of course, we collaborate with our community health resources. We do have integrative health, particularly at our new Forestville Wellness Center, and our mental health and addiction services. This confusing document represents our workflow, and at West County Health Centers, we have empaneled our patients. So each provider has their own panel. Each medical assistant also has their own panel, and the same with the rest of the team. As you can see, we've decided to take the provider work and divide it up amongst the members of the team, and if you look, the provider has significantly a lighter load because the idea is that they're able to distribute that work to other members of their team. Of course, this doesn't happen overnight, and as Catherine mentioned, there is a little bit of resistance when it comes to letting go of all that work. We also have care team huddles at West County Health Centers, and in this particular slide, it really represents our culture shift that's happening. As you can see, the provider is there, and she is listening. She's actually listening to the conversation and to the huddle. There's the medical assistant, and she is the leader of the huddle. She is talking about the flow of the day, and they're discussing what can be done before the provider goes into the room. The day before, the medical assistant has done a robust chart prep, going through any outstanding labs and diagnostic imaging the patient may have, or any alerts that may be due, and anything the provider should bring up. And there's also a front office, and the RN is not in this picture, but we do include RNs in our huddle. The front office is really important to make sure all of our records get in, and making sure all of our insurance is correct, and our nurses are there to talk about those complex patients with the provider, usually at the end of the huddle. We have started expanding the role of the medical assistant when it comes to discharging the patient at the end of the visit. At the end of the visit, the medical assistant will go in the room. They'll discuss any self-management goals that were talked about during the visit and making sure that the patient has a clear understanding of their goal. The medical assistant will also provide a visit summary, which includes an updated list of all of their medications. They do discuss any medications that have been discontinued or a dose change. They also make sure that the patient is clear on any labs or diagnostics that they'll need to get after the visit is finished, and they also make sure the patient is clear on when they are to return. One wonderful thing about this, and one thing that we've found as we've been moving along in this model, is the patient is actually more compliant when their medical assistant gives them the instructions, and they're more likely to complete the tests that are being asked, because they have a relationship with that medical assistant, and that medical assistant is the one that rooms them every time. That medical assistant is the one that calls them to remind them when labs are due, so they have a trust with that medical assistant and understand that they are an extension of their provider. So we're also looking at new ways of using our medical assistants and kind of expanding their role and empowering them. One thing we've done is played around with the idea of having them go to home visits. As I mentioned, the medical assistant relationship with the patient is very, very strong. This actually is me at one of my patients' home, and he was in a critical condition. We could not get him to come into the office, so we had an emergency care team meeting, the provider, the nurse, and myself, and we said, what are we going to do to rope this patient back into the practice? What are we going to do to get him to come in? And my doctor said, well, I think we need to have an emergency home visit, go to his home, and see what we can do to help. The nurse was new to our team. She had just joined, and she said, how am I going to convince somebody I don't even know to come and get treatment, or even let me assess them? And my doctor looked at me and he said, Sheena, you're the way in. The patient knows you. He's known you for years. He trusts you. You go too. And when my provider looked at me and gave me the trust and trusted in me to help participate in this life change or getting this patient back into care, it was probably one of the most empowering moments in my career. And I ended up going there, and the patient saw me, and he recognized me, and it was like a look of relief came onto his face immediately, and we were able to, the nurse was able to come in, successfully assess the patient, and that was probably one of the changing moments in my career, and I was able to make a difference that was positive in that patient's life. Another really exciting thing that we've implemented here at West County is population management. And what it is chronic disease tracking outside of the four walls, taking care of the patients while they're at home and not in the office. This is one of our wonderful medical assistants, Esmeralda, and she is doing her population management time. Each medical assistant is given 4 hours of dedicated closed-door time to do this population management. Each patient that is being tracked for a chronic condition has a standing order that's signed by their doctor and put in their chart. and that allows the medical assistants to order certain labs that are needed in an order set created ahead of time and ahead of the visit. We've also found a high success rate. We did do some measurements and some quality assurance around this, and we did find that the medical assistant calling, making that contact, doing the labs ahead of time did improve our diabetic outcomes. I think this is also empowering for the medical assistant to know that they're able to take care of patients in a different way. I know that when I first started as a medical assistant, I really thought, oh, it's just going to be vitals, injections, and that's it. I looked at medical assisting as a stepping stone in my career, and by this role expansion, it's really allowed me to be able to make a career and grow and do new things, and it's really, really exciting, and I know my staff also feels the same way. We're also doing some really cool things in West County with easy technology. This has to do a lot with the care team and also about how I mentioned before, breaking down the barriers for our patients. Right here shows one of our doctors, and they're using our video technology. One good example of this is he was in with a patient that was very non-compliant, didn't come to the visits, was chronically no-showing. The patient came in, needed an urgent referral, said he didn't get it in the mail, and the doctor said, you know what, I'm going to go ahead and I'm just going to bring the referral coordinator right into the room through the camera. So this has been able to really let the teams collaborate more. Like Dana mentioned, we're all spread out, so we're able to go ahead and bring those people in when the patient is right there. And we also use instant messaging for the providers to communicate to their medical assistants if they need something to be brought into the room. So this has been really helpful and has been able to allow the collaboration of care to be more successful. So that's all I have today, but I did just want to mention that this role expansion is just very exciting for me personally. Just starting out and really thinking that it was really going to be just vitals, just injections, and nothing more. And I'm actually being able to make this into a career. We are looking at ways to continue to grow the role of the medical assistant. A career lattice is being developed. We also do frequent trainings and offer continuing education units to allow the medical assistants to keep their certifications. So we are continuing and growing every day.
Thank you so much. There's lots of questions for you guys, so I'll start going through them, and I think that'll probably take us up until the end of the webinar. Before I pose some of the questions to you, I wanted to let folks know, and I think many have already seen it, I just opened a poll, which is just a quick survey about today's webinar. So if you could take a moment to complete the poll, if you have to get off the phone early, that would be great. You may need to expand the polling menu on the right-hand side of your screen to see that. Okay. There were a couple questions, Dana and Sheena. Could you please clarify the RN to MA ratio in your model?
So the RN ratio is 1 provider to 1 RN. One FTE. Yeah, so full-time. And then our MA ratio is one provider to 1.5 FTE medical assistant.
Okay. So for every provider, there's an RN. And
so for every 1 FTE provider, there's 1.0 FTE RN. For every 1 FTE provider, there's 1.5 MAs. And the 0.5 for the medical assistants, the concept is that when the provider is out on the floor rooming, their medical assistant is out on the floor rooming with them. When we also, for every shift, we have a float medical assistant who's out on the floor just assuring smooth office flow, assisting with immunizations, etc. And then every single one of our care team medical assistants has a 4-hour shift once a week off the floor where they are doing their population management tasks. So that is also part of the 0.5.
Okay, got it. So Kathy, I think that answers your question about the 4 hours to do the population management. So Laura asked, so you have 22 FTE providers. Does that mean you have 22 RNs?
Correct, when we're fully staffed.
Okay. Yeah, when you're fully staffed. Okay. And then there was a question about how long the transition took for, hold on, the decision to implement changing staffing. From the decision to implement, it's from decision to implementation of the changing the staffing ratios.
So this has been part of a discussion that started way back in about 2005, 2006. Our organization really looked at, is very forward thinking and really looked at how we were going to be able to deliver really high quality care and, you know, being stuck in the payment system we're in. And so we really made it a priority and started the planning process. And we started with care teams in 2007, and we've been doing this gradually. So in 2007, we impaneled all the patients to a provider and assigned a medical assistant to the provider. It's only been the last 2-3 years we've assigned an RN to the care team, and we've assigned a front office person to the care team as well. So it has been a gradual progression, but we realized that in order to make the switch for the other roles, we really had to offload a lot of the work from the providers to the medical assistants, from the nurses to the medical assistants. So this hasn't been an overnight project at all.
And it does require ongoing coaching, continuing training. It's not something that you can just, you know, think it's going to end. You know, it's just very ongoing.
Great, thank you. This question refers to the workflows chart that you showed. For the normal tracking that you list under the care team medical assistant role, what does that mean?
So normal tracking is, you know, anything, so the medical assistants are responsible to make sure patients' ordered labs and diagnostic imagings are complete. When the results come back in, it's up to the provider to triage them to either the nurse if it's abnormal or to the medical assistant if it's normal, to either inform the patient or get them to come in for an appointment.
Okay, so the MAs are not the ones. Okay.
They're not making the decision, is this normal or not? No.
Yep, okay. So they're not the initial staff. It's the provider who initially identifies the normal. Got it, okay. What's the difference between population management logistics and population management clinical?
Is that referring to one of the documents?
It must be referring to, oh, it's on your workflow.
So population management, in this context, the logistics is, did patients go and get these labs done? Are these the cookie cutter labs per protocol that I'm responsible for ordering? Population management clinical pieces are the RNs. So they're managing the outliers. They're doing complex care management. They're making the clinical support decisions that a medical assistant cannot.
Got it. Okay. We have several more questions that I think we can try and just get through quickly. Let's see. Do MAs need to be certified to perform home visits? Are they accompanied by someone else, such as a nurse?
So the medical assistants have really only gone on the home visit as the relational piece. They cannot go on their own, and yes, a nurse or a provider does need to go with them.
Great. How are MAs trained to be able to, oh, sorry, go ahead.
I was just to clarify, this isn't something we've been able to routinely build into our workflow. As far as the MAs on home visits, it's been kind of situational, as Sheena was saying, depending on, you know, what the situation is. I think only a small handful of our MAs have even gone. But it is an interesting thought to think out a little bit further.
Great. How are MAs trained to be able to conduct patient teaching, care planning versus an RN's training? And do you have a dedicated MA or nurse trainer?
We do not do patient education. The MAs do not do patient education or care planning. Our nurses do that. We only, at the discharge of a patient, we will only give the patient a handout that's been approved by the provider. We aren't doing teaching.
The medical assistants all have been trained in motivational interviewing, however, and we are having them assist with setting self-management goals. So definitely not the same thing.
Got it. It is 1:30. I will continue to pose some of the questions that are remaining here from panelists. So for those of you who need to sign off, thanks so much for joining today, and please complete the poll before you sign off. For those of you who have remaining questions, I think we can probably just take a few more minutes to finish them, but we won't take any more new questions at this point since we have several queued up. Do you feel that LVNs and LPNs can function in the RN role that you've described here?
We have one LVN in our agency. She was a medical assistant who became an LVN, and we actually created kind of a hybrid position for her. But we've experimented with trying to figure out, you know, should we hire more LVNs versus RNs? Our RNs, their role is still in the process of being expanded and developed themselves, and so we don't know what the end product really is going to look like just yet. So I don't think I know.
Okay, I think that's fair. When you say patient fees, are the patient fees coming from Medicare, medical, or self-pay? Actually, I'm not sure. I don't remember when you said patient fees, but maybe you do.
I don't recall talking about patient fees. In what aspect of the visit? At the end of, or is that?
I'm not sure,
That,
but we can skip it.
That might have been for Catherine. Catherine talked about budgeting stuff a little bit more than we did.
Oh, for the business case. Yep, got it. Okay. Catherine, I know, I don't think you're on mute, Catherine, but she probably had to get off. She visited many FQHCs, so I am not sure across the country. So I think the financial model is probably different in terms of the payers. Okay, let's just take maybe a couple more questions. Oh, Catherine, are you there?
I am still on the line, but I actually didn't quite understand what that initial question was. It's true that we visited
I think given the time, we can probably move forward. I'm going to ask two more questions. If there are other folks who have questions who we didn't get to, it's great, but we have too many actually in the queue. And Dana and Sheena's contact information are available at the end of the presentation. There were several questions about how many patients on average your providers see in a day.
So in order to keep the doors open, we have to hit a baseline of 16.8 in an 8-hour shift.
We often see more.
So that's our goal. That's what we're budgeted for.
So you said 16.8 in an 8-hour shift.
Correct.
Got it. Okay, great. You mentioned, and then I'll just ask one final question about the front office receptionist because there are a couple questions around that. When you mentioned one front office receptionist to each care team, does that mean you have 22 front office receptionists? No, because your care teams include several providers, right?
So if the provider is a full-time provider, they would have their own front office. Many of our providers are not full-time, so we do have a front we do combine front offices, you know, who will have more than one provider on their team. It really just depends on the load, and we have to figure out staffing based on the providers at that site and the hours that they work and their shifts or on their patient load.
So it's not a perfect science. We try to do this with all of those situations. We do have many part-time providers, and we try to marry their care teams. So they may share a load of patients, and they may share care team members.
Yep.
It's not perfect,
and then
by all means.
And then one final question, and I'll queue up the other questions. Perhaps we can answer some of them in the email that we send out. Are the RNs the supervisor of the MAs in this care model?
No, they are not.
Okay. And who supervises the MAs? There's an MA supervisor in particular, right? A separate?
So each of our 3 clinical sites have a medical assistant coordinator, which they, the medical assistants at each site report to that medical assistant coordinator. I, as the agency medical assistant supervisor, the 3 medical assistant coordinators report to me, and then we have a clinical, what is
her job title just changed. I think it's like an agency clinical nurse supervisor, specialist, something like that.
And so she is my supervisor, and she's that clinical oversight, but I am the medical assistant supervisor for the agency.
Which helps a lot when you're talking about workflows across several different sites.
Yes, that makes sense. And then, I'm sorry, one more question. So you said 16.8 in an 8-hour shift. How do you schedule in 15, 20-minute visits, or do you have different times for the different visit types?
Yeah, they're mostly 20,
okay.
And then some of the longer procedures are 30.
30. Okay, great. Well, thank you so much. There was a lot of interest. I really want to thank Catherine, Dana, and Sheena for your time today. We will, again, send out all of this information, including the recording and the PowerPoint, via an email to the email that you sent when you registered for this webinar. So as you're leaving, please take a moment to finish the poll that's on the right-hand side of the screen, and thanks, everyone, for joining today.
Thank you.
Thank you.
Okay.